Thanks to each and every one of you for being here with us today. I, Ankit Dogra, along with my teammates Dr. Deepika Chhabra and Ms. Ramit Saxena from Medical Services, and Mohammad Naeem Siddiqui, Regional Sales Manager, Varanasi Region from Jagsonpal Pharmaceuticals Ltd, are very pleased to welcome you all to the 13th Scientific Sangam, the Funis of Life, Umbilical Cord, organized by ISOPARB Prayagraj in association with OBS and Gyne Societies of Azamgarh, Jhansi and Rewari, with academic partner Jagsonpal Pharmaceuticals Ltd, makers of DIVATRONE, 10 mg tablets of micronized dydrogesterone for a safer and smoother journey to the motherhood. Injection Maintane, 250 and 500 depot progesterone containing 17 alpha hydroxyprogesterone caproate and LycoRed Preg sachets. Dear attendees, if you have any suggestions, questions or clarifications, please post in the Q&A box. Please note this webinar is streaming live on the Facebook. The link is shared in the chat box. Also note, for the future reference, we'll upload this webinar on the Jagsonpal's YouTube channel, Jagsonpal Medical Insights. Now, we welcome and request the organizing chairperson of the program, Dr. Ranjana Khanna ma'am, founder, president, ISOPARB Prayagraj, ICOG Governing Council member, and National Vice President, FOGSI 2017, to kindly take the proceedings further. Over to you, ma'am.
A very warm welcome to all the faculty and the delegates who are watching this program. And first of all, I think we would like to begin by a small prayer. A very good evening, friends. First of all, I would like to welcome our chief guest of the program, Dr. Jayadeep Malhotra. It is such a pleasure to have you on the show, Jaideep ji. She has been the president of FOGSI 2018. I remember when my term as vice president was over, and Dr. Jayadeep had given me all those, lots of things, and it was really fun that time in Bhubaneswar. When you were crowned as the FOGSI president. You are managing, she's managing director of ART Rainbow IVF and vice president, Indian Society of Aesthetic and Regenerative Gynecology, chair FIGO Committee of Reproductive Endocrinology and Infertility, immediate past president, SAFOG, SAFOMS and बहुत छोटा लिखा हुआ है, and is part. Regional Director, South Asia, Ian Donald School of Ultrasound. She is past member of FIGO Working Group and member of Accountability Group of PM and CH. You have done so much in such a short span of life, Jaideep. I think you are full, really full of so much achievements that we all, at least, I think the whole of FOGSI, but especially we in UP, we are extremely proud of you and Dr. Naren. President Rotary Club, President FOGSI ISAR, President Secretary and Vice Chairman ICOG, and you have received so many awards, and you are initiator of Club 35 Plus, Adbhut Matrit iMums app. Yeah, that is gaining so much attraction, and you have really taken Adbhut Matritva to a different level altogether. I have heard your amazing talks on that, and we are really, really impressed with you, Dr. Jaideep, and it's a pleasure having you as the chief guest today. Please accept our welcome.
Thank
you.
Thank you.
I'd love you to say a few words, Jaideep.
Thank you so much, Ranjana. Thank you. And thank you to ISOPARB, each and every one of you. It's awesome to be with you. First of all, please accept my very, very happy new year. And I'm sure this new year is going to bring in lots of health, happiness, peace, and prosperity to everyone. And I'm absolutely amazed at the choice of the topic today, Ranjana. Yeah. Very out of the box, but yet so practical.
Yeah.
And yet there are so many medical legal aspects also related to it, overdiagnosis of the nuchal cord, and many more things. And along with it, I mean, I would be very happy if I would have had a little discussion on interpretations of the umbilical cord flow by color Doppler, especially in timing of pregnancy and all, which could probably be added in future, because that's another very important aspect which we need to discuss. I'm absolutely really, it's such an important topic, and nobody has discussed it the way all of you are going to do it today. And I have seen it being used and abused all the time in our practice. And this is something, a message which I like to give to everyone, because umbilical cord is something which is just bringing nutrition from the mother to the baby. Nothing can go wrong with it on a normal basis. And yet, we have made it like a real big question mark in our practices to do some, I won't say it's unethical, but sometimes I feel that we are so scared of litigations that that's why sometimes when we see a nuchal cord or when we see little low blood flow, and you're so scared as an obstetrician that what happens if something goes wrong with it. Now, I'm sure MC Patel is going to look at, and address all the medical legal aspect of it. But due understanding of the functions of the cord, due understanding of the diagnosis of the various aspects, and a due understanding of the medical legal aspects, along with good documentation and consenting.
Correct.
Is all that is really required, and not only for cord, but for in our day-to-day practice. I am dealing with the PMNCH, and there are many other issues which are going very strong in my day-to-day discussions at different platforms. Only thing which is coming out where I feel which needs streamlining in our practice is good documentation and ethical practices, because we are walking on a very thin line of ethics, and we need to have the patients on our side in our understanding of things, because the moment the patients also understand that life does not walk on that straight rope, and we are also in the same boat as them, I think our patient-doctor relationship also will improve. I'll just give you one small example, because this is something which I've lived with. I was a house surgeon and my co-house surgeon was pregnant. So I had the opportunity of delivering her in the middle of the night. And when I delivered her, the head came out, the cord was 3 times around the neck and 2 times around the body. This was the longest cord I had seen in my life, and she delivered normally. And today, when we see a cord around, I see, prescriptions and ultrasound reports where cord around the neck, advised cesarean. Now, I'm sure you're going to discuss all this and delivering normally, because you talked about IMAMs. One of the major topic which I would like, to be addressed through IMAMs is that we need to deliver more women vaginally. And that's something important, because we need to be as close to nature as possible. And that can only happen with our holistic approach towards pregnancy. So I would really be happy. We have about 4.5 lakh women who are logged on to IMAM's app, but we have 29 million births in our country. So you all can understand how much all of you can contribute. And this in return is going to only improve your own practice and your relationship with the patient, because all that time which we can't give to the patient, this app gives to the patient through all of us. It's a cumulative effort of all of us, which will improve, the understanding of our patients. And I'm happy to announce that we are into our 3rd round of funding for that, and we are going to have another major revamp of the app very, very soon. And thanks to all of you, because lot of things which you have seen, which I have developed, you were mentioning Club 35 Plus or this app, they're only because I understand all of us have less time and we need to educate the patient well, whether it is pregnancy or, menopause or anything. Our communication with our patient is very minimal, and that is something which all these initiatives actually take care of. So I would really feel very happy if all of you utilize all these platforms and let us be winners in every situation. So heartiest congratulations on the choice of topic, on the choice of speakers, and all the best for a great deliberation.
Thank you so much, Dr. Jaideep. And now I will request Dr. Parul to take over.
Good evening to all the delegates and the esteemed faculty. We welcome you all to the 13th session of Scientific Sangam series organized by ISOPARB Prayagraj under the direction of our founder president, Dr. Ranjana Khanna. So without wasting any much time, we start with our first session, which is a talk by our founder president, Dr. Ranjana Khanna. She will be teaching us the basics of umbilical cord. And now I invite our expert for the session, Dr. Alka Sethi ma'am. Ma'am is IMA President 2021-2022, Honorary Secretary, Jhansi Society, Obs and Gynae, City Coordinator, Food, Drug and Medico-Surgical. Yeah, ma'am. So I welcome you. Our chairperson for the session is Dr. Amrita Agrahari. She is Consultant and Associate Director at Phoenix Hospital, Prayagraj, and President-elect Inner Wheel Club of Alka. Welcome, ma'am. I now request Dr. Amrita to introduce our speaker, Dr. Ranjana Khanna. Over to
Thank you, Dr. Parul. Good evening, all. It is my immense pleasure to introduce our ever-smiling, very charming founder president of ISOPARB Prayagraj chapter, Dr. Ranjana Khanna, ma'am. She is a senior consultant and director of Ranjana Hospital, Prayagraj. Ma'am was National Vice President FOGSI 2017. Ma'am was president in AOGS Allahabad in 2013. Holded the post of Secretary and Treasurer of AOGS. Ma'am was organizing chairperson of 2 national FOGSI conferences. BOH was conducted in 2017 in Delhi, and National FOGSI Conference, SAVMA, was conducted at Allahabad in 2016. Ma'am is recipient of many national awards, FOGSI Smriti Mylan Award, Save the Girl Child in AICOG 2013, FOGSI Dr. D.K. Tank Reproductive Health.
I think Amrita, I think I should start my talk.
She was facilitated by various committee of FOGSI from time to time. Ma'am, please.
Thank you so much, Amrita, for this lovely introduction. Funis. Funis is a Latin word which means cord. So we all agree that the cord of life is definitely the umbilical cord. The umbilical cord is the supply line between the mother and the fetus, which provides nutritional and possibly psychological connect between them. The formation starts as early as 5 weeks after conception. Normally, as the cord grows longer, it coils around itself. Cords are helical in nature with as many as 380 helices. It continues to grow till 28 weeks of pregnancy. Normally, the length of the cord is equal to the crown rump length of the fetus. Cord development. The embryo is a flattened disc which is interposed between the amnion and the yolk sac. Its dorsal surface grows faster than the ventral, along with elongation of its neural tube. The embryo starts bulging into the amniotic sac, and the dorsal part of the yolk sac is incorporated into the embryo body to form the gut. The allantois projects into the base of the body stalk from the caudal wall of the yolk sac and later from the anterior wall of the hind gut. The yolk sac becomes smaller and pedicle becomes longer. By the middle of the 3rd month, the expanding amnion obliterates the exocoelom, fuses with the chorion levae, and covers the bulging placental disc and the lateral surface of the body stalk. This is the umbilical cord or the funis. These are the various stages of development. Functions of the cord. Umbilical cord is not directly connected to the maternal circulation, but instead joins the placenta, which transfers materials to and from the maternal blood without allowing direct mixing. Primarily, it serves as a source of oxygenated blood to the fetus. It provides nutrients, including calories, proteins, fats, as well as vitamins, transfers waste products and deoxygenated blood away from the fetus to the maternal circulation, where it is processed and excreted. The features are: the cord is made up of Wharton's jelly. This is the Wharton's jelly, and it has got inside the cord is one umbilical vein which supplies oxygenated blood to the fetus, and there are two umbilical arteries which carry deoxygenated blood to the placenta from the fetus. The umbilical vein goes to the fetal liver, where it splits into two. The first part supplies blood to the hepatic portal vein, which supplies blood to the liver, and the second, ductus venosus, supplies 80% blood to the fetal body. Now we will talk about some abnormalities of the cord. Coming first to the length. The cord length varies from no cord, that is acordia, to 300 centimeters. I think, as Dr. Jayadeep was talking about, it is influenced positively by both amniotic fluid volume and fetal mobility. Short cord less than 30 centimeters may be associated with IUGR, congenital malformations, intrapartum distress, which may be due to hemorrhage, due to premature separation of the placenta, delayed descent of fetus during labor, and inversion of the uterus, and twofold risk of IUD. Long cord, which is could be more than 70 centimeters, may be associated with cord prolapse or entanglement around the fetal body and the fetal neck, fetal anomalies, acidemia, IUD, and of course, it could be associated with true knots, which could lead to fetal asphyxia. Diameter. Normal diameter of the cord is 1 to 2 centimeters. Lean cords are associated with poor fetal growth. Large diameter cords are associated with macrosomia. Coiling. The umbilical vessels spiral through the cord in left twisting direction. Umbilical coiling index is the number of complete coils per centimeters of cord length. Normal value is 0.4 if you do it by ultrasound, but 0.2 is the actual measurement postpartum. Hypocoiling is associated with IUD, and hypercoiling with IUGR and intrapartum fetal acidosis. Both have been reported in trisomic fetuses and single umbilical artery. Vessel number. We have all seen this report on ultrasound, single umbilical artery. The incidence is 0.63% in live neonates, 1.92% in perinatal deaths, and 3% in twins. If this is an isolated finding in an otherwise low-risk pregnancy, it does not increase the risk of fetal aneuploidy. But if it is associated with major malformations, then aneuploidy risk is greatly increased, and we recommend amniocentesis along with fetal echo to rule out cardiovascular and genitourinary anomalies. Remnants and cysts. An umbilical vein remnant, vitelline duct, allantoic duct, and embryonic vessels may be seen, but they are not associated with congenital malformations or perinatal complications. True cysts are epithelium-lined remnants of allantoic or vitelline ducts and are located closer to the fetal side. If multiple, they may be associated with miscarriage, aneuploidy, or structural defects. Now we come to the very important topic of insertions of the umbilical cord. The cord normally inserts centrally into the placental disc. Eccentric, marginal, or velamentous insertions are variants. Marginal, that is the battledore placenta, and velamentous are clinically important, as the cord or its vessel may be torn during labor and delivery. Marginal is more frequent, with multifetal pregnancy, especially IVF conceptions, may be associated with weight discordance. This rarely causes problems, except that the cord may be pulled off during delivery. Velamentous insertion is quite rare. Incidence is 1%, commonly seen with placenta previa and multifetal gestations. The umbilical vessels characteristically spread within the membranes at a distance from the placental margin, which they reach surrounded only by a fold of amnion. As a result, the vessels are vulnerable to compression, leading to fetal hypoperfusion and acidemia. One variant is a furcate insertion. In this, the cord inserts centrally into the placenta, but the umbilical vessels lose their Wharton's jelly before insertion, and they are covered by amnion sheath only, and hence they are susceptible to compression, twisting, and thrombosis. Vasa Previa is a dangerous variant of velamentous insertion. Incidence very rare, 1 in 5,200 pregnancies. Risk factors are bilobate or sexenturate placenta, second trimester placenta previa, and IVF pregnancies. Vessels within the membranes, if they overlie the cervical os, they can be interposed between the cervix and the presenting part. This may lead to compression, laceration, or avulsion with rapid fetal exsanguination. Once Vasa Previa is identified, then we always advise an elective Caesar at 34 to 35 weeks of gestation to balance the risk of perinatal exsanguination versus preterm birth morbidity. Knots, strictures, and loops. True knots, we all know in the long cords, are caused by fetal movements. Incidence is 1%. Common and dangerous in monoamniotic twins, but more so in singleton fetus, where the stillbirth rate is increased by 4 to 10-fold. False knots are insignificant. They are due to focal redundancy of a vessel or collection of Wharton's jelly. Cord stricture is narrowing of the diameter, develops near the fetal cord insertion. They are due to absence of Wharton's jelly and stenosis or obliteration of the cord vessels at the narrow segment. They are associated with stillbirth. Could be caused by amniotic band. Cord loops. We are going to discuss this in great detail. It's coiling of cord around the fetal parts, and nuchal cord is extremely common. This is going to be discussed by Dr. Haresh. And one loop is there in 20 to 34, 2 loops in 2.5 to 5, and 3 loops in 0.2 to 0.5%. Now this picture is showing, this is the false knot. Then this one is the true knot, and we have the nuchal cords. Vascular. Cord hematomas, common associated with abnormal cord length, umbilical vessel aneurysm, trauma, entanglement, umbilical vessels venipuncture, funisitis, and varix rupture of umbilical vein. They appear as hypoechoic masses which lack blood flow on ultrasound. Cord vessel thrombosis, 70% could be venous, 10% arterial, 20% venous and arterial. Arterial thrombosis are associated with IUGR, fetal acidosis, and stillbirth. Umbilical vein varix may be associated with fetal structural anomalies. Umbilical artery aneurysm associated with single umbilical artery, trisomy 18, amniotic fluid volume anomalies. On ultrasound, we'll find a cyst with hyperechoic rim with blood flow. Now, we all know that when the baby is born, then the umbilical cord comes out, and finally we clamp and cut it. Now the question arises when to clamp it. WHO defines early cord clamping as clamping of the umbilical cord within the first 60 seconds of birth. Delayed cord clamping is defined as clamping of the cord 1 to 3 minutes of birth or when the cord pulsations have ceased. Delayed cord clamping causes a flood of iron-rich blood from the placenta to the fetus. This increases the hemoglobin levels at birth and improves the ferritin levels in the first several months of life. This appears to boost the myelin levels in the brain. So this could also potentially impact the brain development of the baby. Delayed cord compression is especially beneficial in preterm infants as it reduces the incidence of intraventricular hemorrhage and necrotizing enterocolitis. ACOG 2018 guidelines say that there is a small increase in the rate of jaundice if you do delayed clamping in full-term newborns. Early cord clamping is done when the baby has to be immediately shifted to NICU. ACOG recommends clamping at 30 to 60 seconds. WHO recommends at 1 to 3 minutes, and RCOG recommends clamping 2 minutes after birth. Now we will conclude this with just a bit about cord blood banking. Cord blood contains hematopoietic stem cells which can transform into any kind of blood cells, and can be used for transplants that can cure certain blood disorders, immune deficiencies, metabolic diseases, and some cancers. The American College of OBGYN and the American Association of Pediatricians say that there is not enough evidence to recommend routine private cord blood banking, except in special circumstances when a first or second degree relative needs stem cell transplant. This is December 2020 guidelines. Thank you all so much for a patient hearing.
Thank you, ma'am, for making giving such a lucid talk. I now request Dr. Alka Sethi, ma'am, to give concluding remarks.
Thank you very much. At the outset, I'd like to thank Dr. Ranjana, Founder President ISOPARB, for giving me a chance to be an expert in this very important topic. And it's a very appropriately chosen topic because it is the least discussed, but most important. It is quite neglected topic. You've really beautifully covered. Your talk was very crisp and very wonderful talk, starting from embryology, functions, abnormality, relevant to obstetric conditions related to it. You took us to our first year MBBS class. Anatomy was beautifully covered. It was fully revised. And starting from that, you touched all the topics, aneuploidy, malformations, and the relation to various obstetric conditions. It leads to various obstetric conditions. The ultrasonological features were very beautifully covered. Clamping cord part is also very important, and it's a hot topic of discussion now. And then last but not the least, most important is the blood banking. That has come up recently, very important. It's a very important aspect which has come up very recently. And I'm sure you'll throw more light on it in the future webinars. Just a single example I would like to give, just as Dr. Jayadeep said, both my children were born normally, but with two loops of cord. First had prolonged labor, second was okay. I was shifted to the OT and my son delivered normally. So it is such an important topic and we should not be scared of cord around the neck. And this also the takeaway I want to give.
It is going to be discussed. It is
Yes.
going to be discussed in great detail.
And I won't take much of your time because we have a long list of eminent speakers. Thank you so much. Thank you for the opportunity.
Thank you, ma'am. I think nobody better than us doctors understand the importance of basics before dealing with the pathology. So after learning the basics, we move on to our second session, which is a talk by Dr. Mitra Saxena. And her topic is cord prolapse, which is a nightmare for an obstetrician. Our expert for the session is Dr. Seema Pandey. CV, please. Yes. Ma'am is Director, Seema Hospital and Eva Fertility Clinic. She is currently President of Azamgarh Obs and Gynae Society, National Executive Committee member of ISAR. She has been awarded as Champion of ISAR and Best Youth Academic Brain IMS State Award 2016 and various other awards to her name. She has co-authored many chapters in a number of prestigious books. A great academician. I welcome you, ma'am. Our chairperson for the session is Dr. Surekha Yadav. Ma'am is President of Rewari Obs and Gynae Society. She has special interest in gynec surgery and has performed over more than 10,000 NDVH in her 15 years of practice. Welcome, ma'am. I now request Dr. Surekha Yadav, ma'am, to introduce our speaker, Dr. Mitra Saxena.
She is a senior consultant and director of Ashwini Saxena Hospital, Rewari, and practicing in Rewari, Haryana. She is the chairperson of Practical Obstetrics Committee, FOGSI, from 2021 to 2024. And she has been active in FOGSI for the last 20 years. She is the past president of ROGS and now chairman of Rewari Obstetrics and Gynae Society. She is a convener and project director of Mukti Project of Haryana Gynae Society. This is to increase the awareness about freedom from unwanted pregnancy, breast cancer awareness, cervical cancer in India amongst doctors and women of Haryana. She is a member of society, various societies like IMA, FOGSI, BGA, IH, ISCCP, and RC and ROGS. Her area of interest include obstetrics and ultrasound, endoscopy, fertility, colposcopy, and contraception.
Okay, Surekha, that's
She has various contributions in various chapters like vacuum, FOGSI, GGPR, and various bulletins in building bridges in Corona times. He is a skilled speaker with academic interest and part of national faculty in AICOGS. Thank you.
So a very good evening to all the people who have joined in for today's scientific session. And at the outset, I would like to congratulate Dr. Ranjana Khanna for having such a wonderful scientific session, all streamed around something as important as the child, the fetus's lifeline, and also our lifeline. I've been entrusted to speak to you for the next 20 minutes on umbilical cord prolapse. I bring you greetings from Rewari Junction, Rewari City, the city with small lines ka sabse bada junction, and my own institute, Shri Ashwini Saxena Hospital. These are some of my references which I have utilized to review and collect data for our talk today. I will try to keep it as practical as possible. All of us are well aware that umbilical cord prolapse is an obstetrical emergency and a nightmare. Due to the asphyxia and acidosis, fetal compromise and fetal demise is almost certain unless the delivery is expedited immediately. The lifeline of the baby, which is at risk because of its getting out of the uterine cavity, the baby is vulnerable to compression of the umbilical vein in the artery, and this compromises the fetal oxygenation. We all must also remember that in addition to a prolapsed cord, where the cord is out because of the rupture of membranes, it could be just a occult, hidden presentation. And if we are vigilant every time and we go over these strategies, which I'll be defining in my talk today, we will be saving a lot of heartache. So occult cord presentation is when the cord loop is there right beside the presenting part. And if we are careful during our pelvic examination, every vaginal examination, we will not miss a pulsating cord. The incidence of cord prolapse is not very high for our benefit. However, we have to always remember that whenever there are malpresentations, especially a footling or a transverse lie, the incidence of cord prolapse is the highest. Now, other things which already have been mentioned and which will be taken in great details are the true knots and the nuchal cords. So true knots, we all know that whenever the cord is too long, it could be because the fetus slips through the loop of cord and there is an actual knot. Thankfully, we don't find more IUDs because of true knots, because the circulation doesn't usually get obstructed. Nuchal cord, I have kept this picture to get that wow factor. And let me give the credit to Dr. Charu Bapa. It was shared in one of the groups, where this is a primee who delivered with 6 loops, normally vaginally. And I also have my own patient, I remember, who had 7 loops, but those were the times we didn't have ultrasound or color Doppler or CTG to see how many loops there are. So this is going to be discussed in detail later. So now coming to what is the etiology and pathogenesis of cord prolapse. We all know that the common denominator is an ill-fitting presenting part into the maternal pelvis at the time of rupture of membranes, which could be spontaneous or iatrogenic. In spontaneous cases, it would be some reason due to the fetal attitude presentation, like breech, transverse lie, or placental, low-lying placenta, or maternal. For example, if this is polyhydramnios, uterine malformations, anywhere, or pelvic contraction where the presenting part is not fitting well. Iatrogenic always is because of the procedure related, and we are all well aware that a little moment of carelessness and you are there landing up into the biggest troubles. So what happens is that whenever the membranes rupture, with the gush of amniotic fluid, a loop of cord can come right down into the vagina or even outside. And of course, during obstetrical procedures, if the presenting part is not well-fitting or it just gets dislodged, it comes down accidentally. Now, this is a very busy slide, but this is just important recap. On the left side are the reasons of fetal, maternal, and placental reasons where there can be higher incidence of umbilical cord prolapse. All these I've already mentioned, but in second twin, which after the first twin is delivered becomes transverse, or polyhydramnios. All these are the reasons for spontaneous rupture and spontaneous umbilical cord prolapse. On the right side are all those procedures along with which umbilical cord prolapse can happen. So whenever we are rupturing the membranes, the presenting part should be well fitting, and this is a very basic fundamental point which we all obstetricians must observe. Whenever we have to introduce a intrauterine pressure transducer or a monitor or a catheter, all these are conditions where it is because of the procedure and little bit of thodi si savdhani hati and durghatna gati. So now what is important is that if it is not addressed adequately, means super fast, then it is going to cause certainly fetal demise. And we have to realize that this causes too much. And there is increased litigation also, and also you feel so sorry to have lost a full-term baby just because of this accident happening. So the delay in diagnosis to the delivery time, delays could be in transfer, getting the definitive management, or also if it's a premature baby or with anomalies, we will be grateful that it is not a healthy baby which we are losing. So we have to remember that the highest reason for litigation in perinatal mortality is because of cord prolapse. So my presentation is not something which we don't know. It is just so that we remind ourselves, alert ourselves and beware. So these are some of the real cases, and I'm sure each one of you has plenty to remember which we have seen or we have managed ourselves. And in every single case, I would say this, that if an obstetrician has been able to manage a case of cord prolapse successfully, that is the baby is alive, then that obstetrician and her setup has come of age. Yani ye aapka ultimate litmus test hai that how well prepared you are to deal with life-threatening emergency of the baby. And it is not just the lifeline of the baby, it's our own career, it's our own practice also, which tends to suffer if we have to face this problem. So now, can we anticipate? Well, friends, routine ultrasound examination is not sufficiently sensitive or specific to identify cord presentation, except where it is done in research setting. So we don't have any guidelines which says that we have to specially look for an umbilical cord which is lying by the side of the presenting part. However, if we are going to keep a breech for vaginal delivery, this could be considered to rule out the presence of umbilical cord to avoid any catastrophe. When to suspect umbilical cord prolapse? So it will be very prudent that at every vaginal examination in labor and after spontaneous rupture, every vaginal examination in labor, and especially after, even if it is a spontaneous rupture of membrane, and of course, if there is risk factor present, this has to be thought in the mind. Only then you will be able to always look for a presentation or a prolapse. After every vaginal examination, after a rupture of membranes, fetal heart should be auscultated. And whenever there is any abnormality in the CTG, we should suspect, in addition to other problems, we must rule out a cord prolapse. And of course, whenever we are examining, of course, if our digital examination is good enough, then fine. Otherwise, it would be sensible to even do a speculum examination and rule it out. Now, these abnormal CTG patterns, which we are getting in a patient who's been laboring and who's had a rupture of membrane, still it would be prudent to think of all the reasons which can cause these abnormalities, which could be an abruption, which could be Vasa Previa, which could be excessive uterine activity, or it could be an occult cord prolapse. So if you think about it, if you know it, if you keep it in mind, then obviously you will not miss it. You will not make the mistake of getting into the wrong place. Now, some strategies which have been defined by the Green Top guidelines of the ICOG, which very clearly say that in transverse lie, oblique lie, and unstable lie, it is sensible to offer elective admission to hospital after 37 weeks of completed gestation. And they should be discussed. This problem that umbilical cord prolapse can happen. So this, at least our responsibility will be shared if we share this information with the patient. Unfortunately, sometimes the obstetricians do not like to disclose. They are afraid that the patient may just change their obstetricians at the last minute. I would still say that it would be better to err on the side of caution. Whenever there is non-cephalic presentations and PPRM, you should offer inpatient care, because if it's an occult presentation of the cord, it could be missed. Again, whenever the presenting part is high, ARM should be avoided. And if it becomes necessary to rupture the membranes with a high presenting part, arrangement for cesarean section should always be in place. This is good clinical practice point. And whenever you're trying to push up the presenting part during examination, you have to be very careful that it should not cause cord prolapse. Similarly, if cord presentation is diagnosed during labor, there is no point in offering any other route but going in for emergency cesarean section. Now, I have recorded, this is a 3-minute drill, which I prepared during the COVID times. So if we have time, I will be showing it. I should have added the word pediatrician also.
खुलने वाला ना
नहीं, पीने के लिए नहीं पीनी।
ये
नोट करिए। That's okay, Risha. My bad technique. No problem.
So, friends, that was a very, not a fantastic drill, but yes, this is during Corona times, and we shot it with my staff, and that is the actual distance between my labor room and my OT. I can find so many lacunae, but this is a drill. But believe me, these obstetric emergencies, if we have practice drills, our staff will be very much ready to deal with an actual emergency. There are so many things which we at one time have to think about. So what are we going to do? What are the important steps in managing umbilical cord prolapse is that we have to do minimum handling of the loops which are lying outside the vagina. There's no point trying to reposit it into the uterine cavity. It was earlier thought so. All we have to do is soak it in warm saline gauze and deposit it in the vagina, but relieve the compression over the cord by elevating the presenting part manually. Now you've seen the posture of the patient, Trendelenburg position, left lateral Sims position. These are all very helpful in elevating the presenting part from and relieving the pressure on the cord. Of course, knee chest is the best position, but that is not so easy to follow for long. There is described a procedure of bladder filling so that the pressure is relieved, but that is important when we have to transfer the patient. And of course, uterine contractions can be stopped by tocolysis. And the bottom line of management is, of course, expediting the delivery, immediate cesarean section, or if it is full dilatation and all full conditions are fulfilled, then go ahead with the instrumental delivery. These are the different postures. So what is important to remember in cord prolapse is where has it occurred? We are best positioned if it has occurred in a labor room which is close to the operation theater, and all our staff is well versed in the drill that who has to be called, what has to be done, and what are the important steps which should not be omitted. Because as Dr. Jaideep had mentioned, that documentation, everything, consenting documentation, making the relatives hear the fetal heart sound, and taking all precautions to transfer the patient, and then of course go ahead with the surgery and pray that God is on our side. So this is how we manage a cord prolapse patient. And of course, it is very important that what is the gestational age, or is it the patient is in early labor or in second stage? When has it occurred? Again, how are we going to transfer the patient if it is at the periphery? How are we going to deliver by cesarean section or instrumental? These are decisions which have to be taken at the spur of the moment. And believe me, it's your capability and the preparedness of your team which helps you get across successfully. And of course, I saw in my drill, I should have said, call the anesthetist and the neonatologist, but sorry for that. But I know that all of you know that we have to have a pediatrician and a good pediatrician, because we may get an asphyxiated baby and we may need intubation. So the OT team, the neonatologist and anesthetist are mandatory to attend to the cesarean section call. Now, the most crucial determinants of favorable outcome, as we see, is the diagnosis delivery time. It's truly a race against time. There's no room for delay and hardly any time to think. All we have to do is a crash cesarean. And of course, this is important that we need some evidences. Sometimes despite our best efforts, we get the baby out within 10 minutes and yet we cannot save the baby. So we have these evidences in our guidelines which say that if the diagnosis delivery time is this much, still, that is a time for us to save ourselves when things are not so good and the outcome is not so favorable. What is important is that if we can protect the fetal life and also not jeopardize the mother. So friends, as you heard me in the drill, this is one case where I really pray to God that the anesthetist arrives in time. And if they don't,
These are the times when we have actually given spinal ourselves, although we don't recommend that because any complication can happen and we don't want to compromise the mother also. The consents, as you saw, they have to be given verbally and signatures, and the choice of anesthesia is regional, not to have repeated attempts. And steps of cesarean section, as you saw, I had instructed my staff that I'll be going in by vertical incision because I think that's the fastest route. Coming to vaginal birth, the problem here is that when you're going to deliver a baby vaginally, it has to be only if it's swift and safe, because relatives will not pardon you if the result is otherwise. So in case of any problem, it would be prudent that you should not be juggling at trying to get the baby out vaginally and even complicating with instrumental delivery and losing the baby. So, well, this is your moment of decision, your expertise, and you are the best judge. Community management, whenever this happens in the periphery, so then our transfer details have to be really good. The link has to be very good. The person who's transferring should do it to the closest unit and give prior information so that the team over there is prepared to deal with this emergency. Believe me, babies have been saved when this linkage is appropriate. We were able to save our first cord prolapse baby only because the first consultant had informed we were ready, cleaned ourselves, scrubbed and ready to receive the patient. There are some special situations which need to be addressed, especially if the gestational age is at the threshold of viability. Then what will be your management? So again, friends, it's your ability and also the level of your tertiary neonatal care. If it is not adequate, then of course you can counsel the patient and the relatives about the survival chances of the baby. So one would reconsider the decision of doing an emergency cesarean section. Again, delayed cord clamping, as Dr. Ranjana had said, well, if you are in that happy position that the baby is crying when you've taken the baby out, you definitely can do a delayed cord clamping. But yahan par to musibat ye hoti hai that you just want an alive baby, and most probably you're going to get an asphyxiated baby. So what is very important is that your own setup, your own team's preparedness to deal with this kind of emergency is very, very important and the most crucial factor. One thing very important to remember even is in the case of a patient that this is kind of a sudden trauma to the mother. So we have to be prepared to deal with the post-traumatic stress disorder, depression, and fear of future childbirth. Even if the baby gets saved, sometimes the panic and the fear is so much because we ourselves are so panicky that the patient may carry it and may actually go into depression, postpartum depression. So what helps these special situations is by having drills and skills. And last but not the least, very good documentation of the events with time. Now, summarizing my talk, this slide says everything. So this is mnemonic CORD. Consider. So when are we supposed to consider that we would be dealing with umbilical cord presentation or labor? Is any and every patient who is in labor can have this emergency at any point of time. So whenever there is abnormality into fetal heart and spontaneous rupture of membranes, please do not leave it to a junior person. If you are the person at the helm of affairs, do a pelvic examination yourself and rule out cord prolapse. And the second important thing is organize help. So if you are to transfer, make all the calls. If you're dealing, call, or your whole team should be at red alert. And if you are quick, you will be able to see it. Important thing to always remember is that we should try and keep the pressure of the presenting part away from the cord so that the most important thing that the umbilical cord goes into spasm is avoided and there is no pressure. So all these positions that I have described is to be thought. And lastly, it is the decision for birth. So the treating obstetrician, the managing obstetrician is the best judge. And friends, honestly, this is a nightmare we do not wish even our worst of enemies to have. But yes, all of us have to be always prepared. And as our teacher always said, what the eyes don't see, what the mind doesn't know. So all I can say is that my message to all obstetricians is never forget that this complication can happen to anybody. So thank you so much for giving me this opportunity to share my experience, for I think that teaching is learning twice. Thank you.
Dr. Mitra, I think it was a wonderful talk, and we all know we have faced it while doing, I know when I was doing PG, I faced it quite a few times. And whenever the cord prolapse used to occur, then it used to be a feat, to shift the patient immediately with the buttocks pulled up and, trying to wrap the thing in the gauze, the cord, and just shifting the patient, one person, and sending an SOS to the OT. One person, wash up. Anesthetist, be ready. The patient reached an immediate seizure and the baby survived. So it used to be such a fulfilling experience, but we know that this is one of the most deadly emergencies of obstetrics, which we all have faced sometime or the other. And nowadays...
Can you hear me now?
Yes.
Yeah.
Sorry, ma'am. Please, you can conclude, then I'll speak.
No, you say, Seema, come on. You are the expert for the session.
Thank you so much, ma'am. Actually, I'm traveling. I'm coming back from Delhi. My son was having COVID, so I just came back. I'm on the way. Yes, ma'am. So I just wanted to say that as a postgraduate students, we were taught when there should be no routine ARM first of all, and whenever you are putting your finger, if ever you have to do, you have to feel. Those days we didn't have routine ultrasound examination, so we used to feel for the cord or something sitting before doing the rupture of the membrane, and high index of that suspicion and this readiness, as Dr. Mitra has explained everything in beautiful detail. It was a wonderful talk, ma'am, and this concept of keeping it was really something very nice, and I really loved attending it. Thank you so much for making me a part of it, ma'am.
Thank you, Seema. Thank you, Seema.
Thank you.
Parul? Ma'am, there are two questions. Yeah. There are two questions for Dr. Khanna. Do you recommend cord clamping to your patients?
What? What's the question?
Do we suggest cord clamping to the patients?
To the patient? No.
Not clear.
The question says that only.
Of course, cord has to be clamped, but we don't have to discuss it with the patient. It's our clinical prerogative. If the child is already very healthy and we don't need to delay the cord clamping because it could just unnecessarily lead to jaundice. But of course, if it's a preterm baby or not so healthy or an IUGR baby, then we can go in for delayed clamping.
Ma'am, can I share my experience?
Yeah.
For last 1 year, I have been doing delayed clamping for every baby. And I'm happy to say, in fact, that the physiological jaundice incident hasn't increased. What my practice is that immediately after the baby is delivered, I put the baby on the empty abdomen of the mother. And I wait till the cord pulsation is over. And then I hand over. Only if the baby is asphyxiated, especially with meconium and all that, then I quickly clamp and hand it over. Otherwise, for all cesareans, all normal deliveries, I am doing delayed clamping.
Yes, and we are all doing delayed clamping, but and
we actually really need to follow it up with baby's hemoglobin in the postnatal period so that we can have our own guidelines.
Yeah. And initially it was said that the baby has to be at a lower level than the placenta but nothing like that. You can easily put the baby on the mother's abdomen and the blood definitely goes there. So, Parul, we can conclude the session.
There is another question for Dr. Mitra.
Which I think
I can't hear.
Ma'am, it is about retrograde bladder filling.
Bladder filling in cord prolapse.
What thing?
See, that is vagus method. That is what they say is, actually this is not when we are transferring in a short distance. Whenever the transfers have to be from the community to the, from periphery to a hospital, because it will not be easy for the patient to be in the knee chest position or something. So bladder filling, actually, when the bladder is full, it pushes the
presenting part
up. So basically, this is recommended that the umbilical cord should be covered with a warm normal saline gauze. You should not be tampering with the cord because that causes more spasm. And it has been seen that sometimes the pulsation may not be there in the cord, but yet the baby is fine. You get the baby out. Idea is just that the pressure from the presenting part, if it is pushed up, so even if the cord will be down, we have to understand that it is mechanical compression of the cord, which is causing the, like asphyxia. So if we relieve the presenting part, we push it up in the, upper part of the lower segment so that the cord, the pressure on the cord is relieved. That is the idea, either by the, anti-gravity positions, Trendelenburg position, or genupectoral, or left lateral Sims position. So these are all to lift the presenting part away from the pelvis. That's all.
But if there are no cord pulsations,
can I add, Ranjana?
Yeah,
Yes.
ma'am. Sure.
Can I add? Can I add something?
Hanji,
okay, then I would like to say that the bladder filling will also going to cause uterine contractions, which will be less, because this is one of the cause of uterine atony. We used to catheter. So that is also one of the reasons. And the other thing is there are only few indications for early clamping of the cord. One is, of course, that the baby is asphyxiated. The other is RH positive and RH negative incompatibility. Yes, and it is the first twin.
It is?
First twin.
Yeah.
First twin. These are the only indication in which we do early clamping. Otherwise, we should always do a delayed clamping. Because this has really resulted in good results.
Yeah. But ACOG says delayed clamping is 30 to 60 seconds. And WHO says it is 1 to 3 minutes. And RCOG says it's 2 minutes.
But when you go to GOI, they say it is the cord pulsation has to stop. And we are staying in India. So we have to follow the GOI.
But madam, GOI, the cord pulsation cease sometimes after a very long time.
I mean, 3 minutes, not more than 3 minutes. 3 minutes, I think, is the upper limit.
Good enough.
Yeah, but even if there is hemorrhage, suppose there is uterine atony and hemorrhage, that could also force us to actually clamp the cord and remove the baby and remove the placenta.
Actually, I think there isn't much debate. Idea is just that the concept of introducing delayed clamping is to overcome the fetal, the anemia, which happens in the neonate. And Government of India guidelines are pretty explicit. And normally, I mean, 1 or 2 minutes is good enough.
Good enough.
Don't really. और अगर बच्चा बिल्कुल ठीक है तो पड़ा रहने दो माँ के पेट पे, वहीं से वो crawling कर लेगा और breast पे भी लगा दो.
But Dr. Mitra, normally if you don't have any pulsations in the prolapsed cord, normally the baby is not alive.
Yeah.
No.
Definitely.
No.
I've never seen an alive baby after that.
See, the thing is this,
alive.
If it is a spasm,
even when the cord, because the only problem is that if the spasm results longer, there are chances of brain injury. So the moment the cord is into the vagina, it is going to go into spasm. It is going to go into the spasm.
Actually, what we should be discussing, and I'm sure Dr. Patel will be discussing that, and that is how to counsel. I mean, I didn't have so much of time, but what is very important is how to, take your decisions and then transfer that information to the relatives that, okay, this has happened and how are we supposed to deal with it? If the outcome is good, we are saved. But if the outcome is not bad, have we done the counseling beforehand? So actually all these things matter.
I think now we should go over to the next session.
Yes. Before starting the next session, Jagsonpal will want to display 1 minute of video. a small video, then we'll start the next.
And besides that, I would like to thank ICOG for granting us 3 credit points.
Yes.
For a safer and smoother journey to motherhood, Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for DIVATRONE.
A very hearty greetings to all the respected doctors. We are immensely happy to share with you that after years of R&D, Jagsonpal Pharma is manufacturing the API of micronized dydrogesterone, which is used in the DIVATRONE 10 mg tablets, making India Atmanirbhar for this critical API, thus reducing the cost to patient remarkably, offering economy of therapy at just ₹50 per tablet. DIVATRONE is freely available at all the counters near you for you to prescribe. For bulk purchases, please talk to our sales team visiting you. The efficacy and safety of DIVATRONE is assured by results of bioequivalence studies. With the addition of this indigenous DIVATRONE 10 mg tablets of micronized dydrogesterone to our product portfolio, we are now able to provide you the cost-effective therapy, and we look forward to your support for DIVATRONE, brought to you by the Jagsonpal, the house of progestins, for a safer and smoother journey to the motherhood. Thank you very much.
Thank you, chairpersons, speakers, and experts for the first session on the very important topic of basics and the cord prolapse. So let's move toward our next very important, somewhat controversial topic of cord round the neck. And we'll deal with the clinical aspects, the ultrasound pictures, and the medico-legal aspects. So to start with, we are going to deal with clinical aspect, which will be taken by the thorough academician, teacher par excellence, none other than Dr. Haresh Doshi sir. And to give the expert opinion and to chair the session, I would like to welcome Dr. Vasa Mukherjee. We all know he's a very young, dynamic, dedicated vice president of FOGSI. And his association with ISOPARB is also noteworthy. He is founder secretary of Kolkata chapter of ISOPARB, and he will be organizing secretary of AICOG 2023. And to co-chair the session and to introduce Dr. Haresh, I would like to invite Dr. Neeraj Yadav, very dynamic, able, and sweet secretary of Rewari Obstetrics and Gynecological Society. She had been instrumental in providing us ICOG point. Thank you, Dr. Neeraj. She is practicing at Yaduvanshi Hospital, Rewari. Over to Dr. Neeraj to introduce our speaker, Dr. Haresh Doshi.
Thank you, Dr. Amita ma'am. Good evening, everyone. It's my immense pleasure to introduce Dr. Haresh U. Doshi. Sir is a professor and head of Department of Obs and Gynae, GCS Medical College, Ahmedabad, Gujarat. Sir has been a faculty of many national and international conferences. Sir is the president of AOGS 2003, organizing secretary for AICOG 2000, chairperson of Practical Obstetric Committee FOGSI 2004 to 2008, and scientific commission chairperson AICOG 2017 at Ahmedabad, and vice president of FOGSI 2019, and altogether a great academician. We welcome you, sir.
Good evening, everybody. Thank you, Madam Lear, for nice introduction. Madam organizing chairperson, Madam Dr. Ranjana Khanna, convener of this program, Dr. Amita, all office bearers of Azamgarh, Jhansi Rewari Society, our chief guest, Dr. Jayadeep Malhotra, my session expert, Dr. Vasa, and all other senior faculties and dignitaries. The topic given to me is cord around the neck. Cord around the neck, or popularly known as nuchal, occurs when the umbilical cord becomes wrapped around the fetal neck by 360 degrees. It is very, very common and controversial. As we all know, around 30% at dawn, probability of nuchal cord becomes higher, following an almost perfectly linear distribution. Whatever is there at 7 months, it may increase to 9 months. that antenatally earlier diagnosed nuchal cord may spontaneously reduce subsequently during the same gestational. Up to half of them resolve before delivery. So you should not diagnose it very early, like 7 and 8 months. It may be cheating. Nuchal cords are rare before 20 weeks because at that time the umbilical cord is very short to around the fetal body. The incidence by number of loops of cord around the neck has been mentioned and studied by Shui et al. Starting from 1 cord 10.6%, 2 cords 2.5%, like that. 4 cords is 0.1% only. But this 10.6% is, as I mentioned in my early slide, is also less. It is now proved that it is as high as 30%. Okay. Etiology of nuchal cord is controversial and unclear. Active fetuses and male fetuses, surprisingly, have been shown to be more associated with nuchal cords. Length of umbilical cord is one of the important determinants of occurrence of nuchal cord as well as number of loops of cords.
We have with us Dr. Mayurika, a very young budding ultrasonologist from the city of Prayagraj. She will be going to take the ultrasound pictures of cord around the neck. And please, to chair and as an expert, I would like to welcome Dr. Kushagar Gawal. He is director at Kriti Scanning Center at Prayagraj. And he is a founder member of ISOPARB Prayagraj. Welcome, Dr. Kushagar. And to introduce and to co-chair the session, I would like to welcome Dr. Gurpreet Patra. She is on member of editorial board of ISOPARB Prayagraj, and she is very active in Society of Menstrual Disease and Hygiene Management. She is very dynamic and is consultant at his Memorial Mission Hospital. Prayagraj, we all know Dr. Mayurika. She's a very dynamic, young and budding ultrasonologist from the city of Prayagraj. And she is going to tell us about the ultrasound picture about cord around the neck. Dr. Mayurika, over to you.
A very good evening to all of you. I am Dr. Mayurika. I work as a consultant radiologist in United Diagnostic Center in Prayagraj. The topic for today's talk is ultrasound diagnosis for nuchal cords. What are actually nuchal cords? Nuchal cord is a situation given when there is an umbilical cord which is wrapping 360 degrees around the fetal neck. It is seen that the incidence of nuchal cord increases with increased gestational age. It is seen that the nuchal cords could be single or multiple, and which can be tightly or loosely wrapped around the neck. If there is a nuchal cord on the onset of the labor, it is very unlikely that it will correct itself. However, if there is no nuchal cord at the onset of the labor, in pre-labor conditions, it is very unlikely that it will occur in the onset of labor. The incidence of nuchal cord increases with increased cord length, small fetuses, vertex presentations, and in polyhydramnios. What are the types of nuchal cord? According to the Giacomello classification, the nuchal cord has been divided into 2 types. A type A, which is a freely sliding pattern. In this, the placental end crosses over the umbilical end or the fetal end. And in this, this pattern can undo itself. However, in type B, this is a locked pattern in which the placental end crosses under the umbilical end or the fetal end. This is a locked pattern and it cannot be undone by the fetus and has got a high potential for fetal morbidity and mortality. These are the 2 images in which we can see this is a type A pattern in which the placental end is above the fetal end, and this is a type 2 in which the placental end is below the fetal end, and we can see that it will not unwrap it itself. It will be a locked pattern. These are the 2 ultrasound pictures in which this is a type. These both represent the type A pattern, and then we can see that the placental end is above the fetal end, and it is a sliding pattern. This is the type 2 pattern or the type B pattern, in which the placental end is below the fetal end, and it hence becomes a locked pattern. What are the ultrasonographic findings? On a basic grayscale image, you'll see a small dent or an impression. on the fetal neck posteriorly on the sagittal planes. And this name is given as grayscale divert sign. When we switch on the color Doppler, we'll see a structure wrapped around the fetal neck, which will represent the color flow patterns very similar to the umbilical vessels. Color Doppler also helps us to assess the number of cords around the number of cords in sagittal sections. This is the grayscale image in which I was telling that there will be a small depression posteriorly on the fetal neck on sagittal section. When we switch on the color, the fetus, this depression will take up the color, and hence we can diagnose it as cord around the neck. When these depressions become much more prominent, they become more indicative of tight cord around the neck. This is the sagittal image, which shows there is a cord around the neck, single loop, and this is the 360-degree encirclement of the fetal neck by the cords. And very well seen in this picture. This is a sagittal image, this is a cross-sectional image, and you can see there are multiple loops of cord around the neck. What could be the differential diagnosis? Differential diagnosis are posterior cystic masses, folds of skin, amniotic fluid. Posterior cystic masses like cystic hygromas. The differentiating point is the color Doppler. When we switch on the color, we see that there is no color uptake in such posterior cystic masses. However, when there is a cord around neck, we'll see the structure to take up color Doppler very similar to the umbilical cords. Another could be a redundant cord lying on the side of the fetal neck. Thank you.
Thank you, Dr. Mayurika. I would request Dr. Kushagra to give expert opinion about the ultrasound picture. Dr. Kushagra?
Yeah, I'm there. Thank you, Dr. Mayurika, ma'am, for your wonderful presentation. And cord around the neck is so common and so frequently seen that we really can't afford to miss it on ultrasound. And thank you again for your very lucid and wonderful illustration of cord around neck and its types and really good ultrasound images. Thanks a lot.
Thank you.
Thank you, Dr. Mayurika. It was such, as we have discussed, it was very precise, to the point, and we are able to grasp all the images from your presentation. I think, thank you, Dr. Mayurika. Thank you, Dr. Kushagra. And Dr. Harish sir, are you there?
Yes. As the period of gestation increases, the probability, as Dr. Mayurika said, the cord around the neck increases. But one should remember that antenatally diagnosed at 7 and 8 months may not be there persisting at the later gestation. Up to half of them resolve before delivery. Can you see the next slide? Yes? Okay.
Yes, sir.
Yes, nuchal cords are very rare before 20 weeks because the cord is very short to go around the body of the neck of the baby. The incidence, as mentioned here, it is decreasing as the number of loop of cord increases. But this was by Shui et al. But he mentioned only 10.6%, but otherwise it is as high as 30% in single loop of cord. The etiology is controversial and unclear. Active fetuses and main fetuses surprisingly have been shown to be more associated with nuchal cords. Length of the cord is important determinants of the occurrence of nuchal cord. Also, the number of loops. We all know that cord at full term is 50 to 60 centimeters long. If the cord is more than 70% long, that is right, which is found in 4% of cases, that long cord, they are more likely to be associated with poor fetal outcome. Apart from nuchal cords, other fetal problems because of clotting and other entanglement also. However, is the longer umbilical cord the cause of the nuchal cord, or does the nuchal cord cause the umbilical cord to stretch afterwards and lengthen? It is not solved. It is not solved. Since science has not yet solved this, whether it is a cause effect or a result effect. Okay. Fetuses, this is nothing new. Fetuses with less vascular coiling have more chances of nuchal cord. Strong has long back 1994 developed coiling index. Means umbilical cord coiling index is defined as the total number of coils divided by the total length of the cord. If there are more coils, right, the less risk of cord around the neck. If there are less coils, hypocoil, it has more risk of nuchal cord. How do you define this? Number of coils per 1 centimeter of length of the cord. Normally, in a cord, every 5 centimeter there is one complete cord. If it is more than one coil in 5 centimeter, it is hypercoil. And if it is less than one coil in 5 centimeter length, it is hypocoil. Right. So when it is normal coil, it is following index. What is this? Normal coiling index is 0.2. 0.2 means 5 centimeter, one coil. Right. So that is there. If it is normal coil, the percentile is normal range. If it is hypercoil, more than 90 percentile. When it is hypocoil, there are more chances of nuchal cord. Encirclement of umbilical cord around the fetal neck is rather commoner. Whether it is related to increased fetal morbidity and mortality is controversial. Loose nuchal cord is never associated with adverse, we all know, perinatal outcome. Incidentally, when the cord is around the neck, this is one school of thought that it is there in the groove of the neck, it is rather protected from compression. See this gentleman, he is having something around the neck, and this celebrity is protected from something around the neck. So that was also one thought. Okay. The primary misconception is that the cord is being strangulated and suffocated by the cord around the neck. But this is wrong. This is the fetus cannot breathe within the womb. It is the mother who delivers the oxygen. It is not like strangulation of human being like ours, where the air pipe is also strangulated. It is only the vessels which are there in umbilical cord, and not the neck of the baby is that much compressed. So that is a wrong fallacy. If the cord compression is not prolonged, the FHR, fetal heart rate and metabolic status can rapidly normalize because of diffusion of carbon dioxide across the placenta. It is wrongly assumed, I underline that nuchal cord really causes cord compression and postpartum intrapartum complication. Greater than 50% interruption of umbilical cord is required to produce problems, and which is not happening in most of the cases. Nuchal cord did not increase fetal morbidity and not a significant effect at abrupt. So this is proved by many studies. I have not proved the studies here, but almost proved by many studies. So what evidence says? No harm is more than the harm it causes. So we should be rest assured. Now I am putting this brain teaser for anybody to answer. What maximum number of loops of cord around the neck is reported? Right, 6, 7, 8, 9, 10, 11. My number is this. You can now WhatsApp to my number to get the prizes. I will courier the prizes to the winners. Okay, first come first. Okay, I will give the answer later. Nuchal cord, okay, it is only tightness of loop or multiple loops, 3 or more, adversely affect the perinatal outcome. What is this? Intrapartum fetal heart rate deceleration, meconium staining, low of gut score, and increased intervention. Okay, that we all know. A recent study by Henry et al. Suggested that something like tight nuchal cord, it occurs very rarely. In 2 lakhs years, only 6%. 6%. So when it is called tight, when you are unable to manually unloop the cord over the baby's head, it is like this, very tight, this picture shows. Okay. The cluster of cardiorespiratory and neurological signs and symptoms associated with unique physical features that occur secondary to tight cord around the neck has been referred to as Tecan syndrome. Tight cord around the neck syndrome. That is the Tecan syndrome. What happens in Tecan syndrome? Umbilical cord compression due to Tecan syndrome may cause obstruction to flow of vein. Vein is a thin wall. So umbilical vein will be compressed first in Tecan, and the artery will still pump the blood out of the baby's body to the mother. So baby will become hypovolemic and hypotensive, resulting in acidosis. So that Tican syndrome, this way, right, pathophysiology of Tican syndrome, that first obstruction of the veins, and that is also sufficient to produce problems. Now that is already told by Malvika madam that right, it is significant incidence of stillbirth and perinatal with type B type of twin lot fashion. She has also shown these slides, right? When this type A, when the placenta end crosses over, right, over the umbilical end, then there is no, this can unload, easily unload. But if it goes below this, it can produce a problem, cannot undo itself, and it is a strangulating. The challenge is now coming to the clinical diagnosis. The changes in the fecal artery distillation produced by something shown by Mendes et al. That you can at full term, at suprapubic region, you can press your fingers and hand and manually compress the fetal neck area. If there is a deceleration at late pregnancy and internal checkup, you can think of that this as a cord around the neck, which will this positive test. It has a high sensitivity and high specificity, 82.3% and 89.1%. This positive test implies an impending risk of compression as an indication for close monitoring of the fetus during labor. Okay, so as 2D images, she has nicely mentioned, Malvika madam, and this video, live video, shows you the right cord around the neck, and also right color Doppler is better than 2D because color you can see all around the fetal neck, right? But one point important: avoid over-diagnosis at USG. Look of the cord may be merely adjacent to neck and not round the neck. So you have to note it total 33, 60 degree. Then and then you should say it is a right cord around the neck, not just some color around the neck. You can see now this side it is coming in this picture, it is coming on this side also. So it is definitely right cord around the neck. Okay. Now DIVAT sign also madam has told that DIVAT sign here, that is by cord, the neck is compressed. So 2D, you require a high resolution 2D machine. Right, then DIVAT sign also suggests buccal cord. Pressure on the skin of the neck. Diagnosis in labor. During labor, the only indication of the umbilical cord being wrapped around the neck is variable fetal heart decelerations on the fetal monitor. They may also be timed with contraction because at contraction the cord gets stretched more. So there may be also late deceleration. So it is said that typically double variability is diagnostic of fetal buccal cord. Even simple late, variable deceleration is also sufficient. But if you have W pattern, double time dip going down, the dip going down, then also. What are the other features apart from fetal artery variability? Failure of descent. If the passenger and power is normal, then also with contraction after half an hour the head is not descending, you should think of cord around the neck. Because it deflects head, it is not correcting in the pelvis, and head is receding in between contraction. Suppose some descent occurs, but when the contraction passes off, the head goes up. That will tell you the right cord around the neck. Now answer of my question, which I put earlier, it is a D, 9. Correct answer is D. Right, maximum number, right, reported is 9, right? The person will get the prize. Coming to the management, USG diagnosis of buccal cord at the end of pregnancy should not be an indication of cesarean section, which is in practice happening, which should not happen. Patient should be advised the importance of monitoring fetal movement in the rest of the pregnancy once you diagnose antenatally on sonography. If some change in fetal movement, she should report immediately. Otherwise, if detected during antenatal period, then okay, close monitoring FHS is advocated in labor, like we do it in other cases, like oligo, thin leukocyte, we closely monitor. Here also we should, if you diagnose earlier, we should just go closely monitor and not straight away elective cesarean section. In labor, at the time of delivery, loose buccal cord can be slipped over the fetal head or over the fetal trunk. But if it is tight, somersault maneuver should be done rather than cutting the cord. As Mitra madam has already told, that produces early cutting, causes hypovolemia and seen in the anemia. So all guidance, all guidelines, and our government of India also telling late clamping of the cord. So here somersault maneuver is important, right? Somersault, now what is that maneuver? It involves the putting the palm of the head over the occiput and gently pushing the baby's head towards the mother's perineum, thigh. the baby's neck thus remains close to the mother's perineum, and flexion of the waist encourages the flexion of the waist of the baby and baby delivery, right, by maternal effort. Now, I think the video is there. I hope it works, right? Okay. See, I cannot edit this, so 30 seconds are for her speech, and then she will show the typical somersault maneuver. When the head is delivered, you press the weight towards the mother's thigh, and the rest of the baby comes out. So that will be shown in this video. Right now, the head is there. The head is delivered, and then loop of the cord. What she will do, she is the flexion side, so right side of the thigh of the mother. Right this way, somersault. So this way. So more pressing, not pulling it down towards the mother, it is pushed back, and this is right. The baby is delivered, and you can see the nice somersault without somersault complete, and the loop is undone. Right, this is a nice. And without cutting the cord, you can do this. Okay, conclusion. Nuchal cords are noted frequently, right, in very high percentage of otherwise uncomplicated pregnancy, with subsequent uneventful deliveries in the vast majority of the cases. Patients and relatives should be counseled and reassured adequately of the high probability of anticipated unaffected outcome. The presence of nuchal cord should not be a matter of apprehension or anxiety. Mode of delivery does not change with the detection of nuchal cord antenatally. Close monitoring of FSH and progress of labor is advocated. Because of our current management strategy, normally we manage in our patient in labor with slightest fetal distress, we go for it's sufficient for nuchal cord also. Don't anticipate that severe complication and go for early cesarean section. Multiple or 3 loops of cord and tight loops of cord can definitely have some adverse outcome. So, but at present, the expertise to diagnose multiple and tight loops on sonography is limited, and this should be the aim of the future research. Thank you very much.
Thank you, sir, for the brilliant deliberation. I would request Dr. Basab to give concluding remarks.
Thank you, Dr. Harish. It was wonderful. I couldn't hear the initial part. I was a little busy in a meeting, but wonderful take-home messages of the nuchal cord. There was also a question about whether ultrasonologists should actually report nuchal cord. That is something which outside India, people who are trained in UK and abroad, they don't even mention it. But in India, somehow we are a little stuck, and we just keep on expecting and stretching our imagination when we have a nuchal cord, and we really need to know everything what you told us. It is wonderful to hear the sonography nuances that you had mentioned, and I'm sure everybody will have something to share. Dr. Ranjana, first of all, congratulations to you and ISOPARB to bring in this umbilical cord as a subject on a topic of a discussion. I think that's something very unique. We have been to so many academic forums, but an umbilical cord specific academic session is something very rare. And thank you for bringing that up, and thank you for, because it's so important, yet it's so less spoken of.
Exactly.
Sometimes you take it with the placenta, sometimes you take it with the membranes, you take it something different. But umbilical cord standalone session is something quite unique, and it's very interesting because everybody has their personal experiences to share, and everybody they can relate to a lot of the talks and the difficult clinical scenarios which have been explained by the experts here. Thank you, Dr. Harish. I'll hand it over to Dr. Amita, Dr. Ranjana, Dr. Mitra, Dr. Alka, Dr. Manju. Thank you for calling me here. It's a pleasure.
Thank you, Basab, for coming and sharing your views as an expert.
Thank you, Dr. Basab, Dr. Harish sir, for this brilliant talk. And so moving towards the last, but I can say the highlight of the program, what are the medico-legal concerns about the cord around the neck? And to deal with this today, we have a famous medico-legal expert of FOGSI, Dr. MC Patel sir. And to chair the session, we have my teacher and the expert for this session, Professor Dr. Manju Verma ma'am. She has been past president, UP chapter of obstetrics and gynecology, and she has been recipient of various awards, and she's like just like a lighthouse for all of us, guiding us, holding our hands, and she's I can say, a solution for our every academic problem. Welcome, ma'am. And to co-chair the session and to introduce our speaker, we have Honorary Secretary of Azamgarh Obs and Gynae Society, Dr. Archana Messi, and she has been past Secretary of IMA Azamgarh, and she's Director of Sanjeevani Hospital, Azamgarh. I would request Dr. Archana to please kindly introduce Dr. MC Patel, sir. Over to you, Dr. Archana.
Hello.
Yes.
Hello, am I audible?
Yes, yes.
So here I am here to introduce Dr. MC Patel, and he is ex-Vice President FOGSI. He is past Chairperson Ethics and Medical Legal Committee FOGSI, Honorary Joint Secretary State Organization of Gynecologists and Obstetrician of Gujarat from 290 to 20, Honorary Member National Inspection and Monitoring Committee PNDT Act, Government of India 2015, Honorary Member State Supervisory Board PNDT Committee Gujarat State 2005 to 2009, past President Ahmedabad Obs and Gynae Society, Honorary Member National Managing Body Indian Red Cross Society headquartered from 2019 to 2022, National President National Medicos Organization 2016 to 18, President IMA Ahmedabad Branch 2007 to 8, Honorary Surgeon Indian Red Cross Eye Bank. He has collected more than 1,000 eye pairs. Past Joint Secretary Umia Parivar, Ghat Lodhia, Ahmedabad. So this is it. Over to Dr. MC Patel.
So, greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Cord around neck or knuckle cord, whatever we say, medico-legal connotations. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank Allahabad or Prayagraj Umbilical Society and Dr. Ranjana Khanna and Amita Tripathi in particular for inviting to share my views about the subject. Usually I start my talk with this: is it worth discussing? Yes, and if it is yes, then what? So let us see the statistic. It is statistic from Professional Protection Scheme, which is run by Indian Medical Association Gujarat State Branch. On 2017, 31st of March, total enrolled members were 11,979, and out of those, 2,359 friends were facing litigation in one way or other, either notice stage, district forum, state commission, national commission, Supreme Court, criminal cases, civil cases. And see, increasing number of enrollment of members in 2021, 16,485, and out of those 3,113 members were facing litigation in one way or other. So see the increasing trend of number of litigation, and it simply comes to 18 to 20%. So it simply means that every fifth medical person is facing litigation in one way or other, and medical litigations are increasing in number constantly and steadily. And unluckily, we gynecologists rank first as far as medico-legal consequences are concerned, because in our day-to-day obstetric practice, we take utmost care of our patient, but accident may happen at any time in obstetric practice, and it may end up into litigation many of the times. So which are the areas for litigation as far as cord around neck or knuckle cord is concerned, and where thing goes wrong? So let us see. Usually whenever you are facing any case in court of law, this common question is asked: was it preventable? But as far as cord around neck is concerned, naturally we cannot prevent it because it is not in our hand. But more problem or question on prosecution will be asked: why you couldn't prevent it? And again we can explain it is very natural phenomena and one cannot prevent it. But very important question comes, did you diagnose in time? And if you have diagnosed in time, that very important question will come. Did you manage way in which any prudent doctor would have managed? Once you have diagnosed cord around neck, then did you manage the case way in which any prudent doctor would have managed? If you can answer all these questions, then you are out of problem whenever you are facing this type of litigation. So let us understand in a very simpler way, what is negligence? During our medical curriculum, we were taught two words, act of omission and act of commission. Act of omission simply means not to do something which a reasonable prudent doctor would do. Say for example, giving full dose of penicillin without doing test dose. It is an act of omission. An act of commission means doing something which a reasonable prudent doctor would not do. Giving general anesthesia on full stomach in a planned surgery. So these are the examples as far as act of omission and act of commission is concerned. When any patient enters in your clinic, in your consulting room, and once you accept to treat her, it becomes a contract or implied contract between patient and yourself. And legal duty stems from acceptance of a duty in a legal way. So once you accept to treat any patient, your legal duty starts from that point of time. And if there is a breach of that legal duty or care owed to the patient by which, well, by doctor, whereby patient suffers damage, either physical, either psychological or financial, then it becomes a case of negligence. So there are 4 ingredients of negligence. To prove in court of law negligence against any medical person, there should be these 4 ingredients. 1, existence of legal duty. So once you treat, accept to treat, it starts. Breach of that duty, that is carelessness on part of treating doctor or negligence. Damage suffered by patient. Due to that breach of duty, if patient has suffered any damage. And very important point, doctor's conduct is direct and proximate cause of such damage. So action taken by doctor should be direct and proximate cause of suffer patient has occurred. So as far as existence of legal duty is concerned, healthcare provider is legally duty bound to provide to the patient. And as far as this part is concerned, medical negligence is defined as a lack of reasonable care and scheme. In famous case of Jacob Matthews, it was discussed and decided, and Supreme Court has very specifically mentioned that one should exercise ordinary skill and reasonable care. Here, what extraordinary skill was not used or extraordinary care was not used. Ordinary skill and reasonable care is sufficient for any practicing medical person. And willful negligence on part of doctor. So if it is accepted, then these are the certain area. First, in acceptance of the patient. If you have accepted the patient, then you have to treat. Because in eye of law, when you claim to be master, then you are supposed to be master. So whenever you accept patient, you should know your limit. And if you are able to deal with, then only you should accept the patient. History taking is very much important. Examination, diagnosis, investigation, and naturally treatment. So these are the areas where one can end up into litigation. And as far as common allegations for litigation in this type of patient, when there is a cord around neck or so, improper diagnosis of fetal distress leading to delayed delivery, improper monitoring of process of labor leading to complicated labor, improper interpretation of CTGs, improper application of instrument for operative delivery, and many a times as far as role of cesarean section is concerned, on one hand, media is crying loud that there is increasing rate of cesarean country. And on other hand, there is allegation on part of patient and relative also. Why you didn't go for cesarean section in time? So litigation for not doing cesarean section in time is one more area. So medical practitioner has to balance all these points. So as far as cord around neck cases are concerned, every case of cord around neck may be, not always, may be potential threat as far as medical legal problems are concerned. So looks like avoiding medical legal problems in our practice is a difficult balancing act. No, not at all. Then what to do and how it can be prevented? So practice foreseeability, that is anticipation, good communication and consent, and proper documentation, and you will be simply sail through. So as far as foreseeability is concerned, you should anticipate once it is diagnosed that there is cord around neck, that you should anticipate that if it is tight cord around neck and baby may go asphyxiated, and you should be readily available to deal with the situation accordingly during labor and just after delivery as far as baby part is concerned. So inviting neonatologists in your labor room at the time of delivery or so. So if you have foreseen, if you have anticipated problem, and if you are dealt with accordingly, then you are out of problem. But in all this situation, proper counseling is very much important, because once it is diagnosed as a case of cord around neck, proper counseling is very much important, because it is very obvious. More is the time you spend with patient in consulting room, it is less is the possibility you needing to spend time with that patient or relative in courtroom. So if you spare enough time in consulting room, counsel patient about cord around neck, then you could be out of problem as far as medical legal problems are concerned. So naturally communication is key to avoid litigation, and it is very obvious. We might have the best medicine in the world, but it won't be successful if patient doesn't understand it. So proper communication is very much important. And usually how we start our consulting, what is the complaint? Usually this is the story, and there are so many questions on part of patient. If we have diagnosed and told patient that it is cord around neck, then naturally there could be many questions on part of patient. Why did it happen? How it can be avoided? Will it happen again? Could it have been avoided? So there are so many questions on part of patient. So at the time of counseling, common questions asked by the patient, if we encourage patient to ask related to cord around neck, any question if she has, then there are usual questions she will ask. Why does a knuckle cord or cord around neck occur? And usually we cannot explain exactly, but we can say there could be possibility of extra long cord or excessive amniotic fluid, and in few of the condition, twins or multiple pregnancy, there is a possibility of cord around neck. One more question will be, is cord around neck dangerous? So an umbilical cord may cause concern in rare cases if it is wrapped tightly around the baby's neck, or if it gets pressed while the baby is descending through birth canal. So we advise mother to follow up regularly so we can assess how baby is doing. One more question, how do you remove a double loop of cord around the neck? We know it is not possible. Once it is cord around neck, naturally it can be removed by its own. Otherwise, it is not possible. So there is no particular way to remove a single, double, or multiple loop of cord around the neck. And cord can slip off on its own as baby continues to move in the womb. So you can explain this to the patient at the time of counseling if there is question on part of patient. The only action she can take is to stop stressing about it, as this will do her no good. So we have to give assurance and explain everything. One more question on part of patient could be, is normal delivery possible with cord around neck? And we should explain, yes, babies are often born safely with multiple loops of cord around their neck through normal delivery. But in few of the cases, When the cord around neck doesn't come off the baby easily, doctor may decide to clamp and cut the cord and then deliver the baby. One more question on part of patient, and it is a common worry on part of patient. Does cord around neck mean cesarean section always? So we have to explain again. Fetuses with 3 to 4 loops of cord around the neck have been delivered by normal vaginal delivery, and at the same time, some cases have to be delivered by cesarean section due to fetal distress caused by a even single loop of cord around the neck. So at the time of counseling, we should be very clear as far as our counseling part is concerned. But it is very obvious. The fetal problems, especially those leading to permanent liability, are more likely to end up into litigation. So we should explain everything to the patient as far as cord around neck is concerned. And we should offer all the alternative modalities of treatment with possible morbidity, with probable expense. In few of the cases about the mortality on part of fetus, prognosis, probable complications, risk involved, and as far as outcome of baby is concerned, it is very much important to be explained to the patient in case of cord around neck, and need of an ICU care if at all it is needed in few of the cases. So it should also be explained, but it should be explained in a very simple language, no much medical jargon. We should explain everything in a way or language which patient can understand, and no rosy picture about result or no tall claim about result. Because just I mentioned, when you claim to be master, then in eye of law, you are supposed to be master. And in our obstetric practice, we consider our practice like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture about result. So proper communication with the patient in case of cord around neck is very much important. And once you have counseled everything to the patient, and once you take signature on consent paper, then it becomes a documentation of your communication. Because in this famous case of C. Jaipal Reddy versus Padmini Velluri, National Commission has very specifically mentioned that consent paper is not mere piece of paper where patient or relative has to sign, but it is a very important document of your counseling, of your communication. Whatever you have counseled to the patient about given situation, or whatever you have counseled to the patient about your future treatment plan with income and probable prognosis is very much important. So it is a very important document of your communication as far as consent is concerned. And when you offer this consent paper in court of law, it becomes a communication of your documentation. But in all this situation, well-informed consent is a very important defense. So it should be taken into consideration in that way. Many a time patient may refuse to give consent, whatever you have counsel about cord around neck. So is it expected to take a written consent for refusal also? If patient refuses to give consent, or if patient refuses for your treatment plan, then negative consent is also very much important. And in few of the cases, even in this situation, patient or relative may refuse to give negative consent also. So in this situation, you can have a signature of any visitor of your hospital, any co-patient, that it was explained before us to the patient, everything was explained about cord around neck and treatment plan, but patient and relative refuses to give consent, then you are saved in court of law. So is it expected to take a written consent for refusal? Naturally, yes. But in all this situation, how you will prove that you had counseled patient well, and records are always at your rescue. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court of law. Because a doctor is bound to produce record whenever asked by the court, and if he doesn't, then adverse inference might be drawn. And naturally, good record is good defense, poor record is poor defense, and no record is no defense. And it has been my experience during my medical legal practice. We doctors' friends are very poor as far as record keeping is concerned. As far as era of COVID-19 is concerned, at the time of taking history and at the time of counseling the patient, possibility of spread from patient to others, from others to patient, all the precautionary measures should be explained, and we should ask history about international traveling, interstate traveling, contact with COVID positive patient or a COVID positive patient in family or any quarantine home or hospital. And if at all patient turns out to be positive, then please inform appropriate authority as per government notification. And if your hospital is well versed with a COVID positive treatment patient, then you can deal with situation at your hospital only, or you should refer patient to respective center where COVID care positive patients are taken care of. And it is very obvious, it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. And there is always a way. So carry home message, minimizing the claims or number of litigations. Antenatal and labor ward protocols, you have to strictly follow, and you have to prove in court of law also that you had followed that those protocols. Adequate supervision and monitoring during antenatal period, during labor and just after labor. Communication and counseling and proper consent. Documentation and proper record keeping. Foreseeability and anticipation, and audit of your own medical cases. So it will be helpful to brush up your practice in future also. So in spite of all our this professional and occupational hazards, our journey to serve human and mankind is always on and on. So if you want to sleep like this, take tender care of your patient and be informative to your patient about any condition whenever you are counseling the patient. Pray Almighty God before going to sleep and keep my visiting card below your pillow. So this is law of leopard behind innocent gynecologist, and see the role of medical legal counselor, how he can be useful in any given situation. So do not hesitate to ask opinion or help or assistance from any medical legal counselor. So सत्य परेशान हो सकता है लेकिन पराजित नहीं. So we salute to the organizers, and again thanks to Dr. Ranjana Khanna madam and Dr. Amita for inviting me to share my views about the subject. So thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you very much.
Thank you, sir, for wonderful insights. I would request Dr. Professor Manju Verma to please give concluding remarks before we proceed.
Am I audible, Amita?
Yes, madam.
Yes.
Okay.
Yes, you are.
Thank you, Ranjana. You have really organized this so nicely. I will only wish, you have more success. And coming on to this subject itself, I must thank and congratulate Dr. Patel. It was really a pleasure to listen to you, and I thoroughly enjoyed your talk as well as your presentation. Coming to the subject itself, I would like to say that there is no way to prevent nuchal cord, right, from happening, but the consultant should know how to prevent injuries and the long-term damages that it can cause. I would like to say here that presence of nuchal cord per se is not an indication for cesarean section. I have delivered a patient who has 7 loops around the cord in 1972, and the person is an IAS person. So, you just cannot from the very beginning predict what can happen. But the nuchal cord can cause complications due to hypoxia as well as due to strangulation. And there is a long, and this can result into, as already been described by Dr. Patel, that it can result in physical, mental, intellectual, and may even permanent disabilities, and even death can occur because of that. And there is a long list of, nuchal cord complications that can occur. Hypoxic ischemic encephalopathy, cerebral palsy, brain damage, fetal death, meconium aspiration syndrome, umbilical cord artery ischemia, and clotting, developmental delays, FGR, and a lot of the complications that can occur. So I would like to say here is that risk factors has already been told by Dr. Patel. And I would like to add here that in the literature, there's also said that there's some cord structural anomalies, like that maybe in the little amount of Waters jelly, or, they may be responsible for cord around the neck also. So here I would like to simply say that, if a nuchal cord is found and the baby is injured, it is considered to be a negligence, as already been said, or medical malpractice, which is nothing but deviation from the standard protocol or care which has to be taken. And therefore, this means that there has been either an act of omission or an act of commission which has occurred. Just to enumerate and summarize here, if there is a failure to recognize fetal distress during labor or delivery, this is likely to be going for the person can sue into the court. Failure to perform an emergency cesarean section if necessary. If you detect a fetal distress, do immediately a cesarean section. Failure to perform a scheduled cesarean section, you plan a cesarean section, and if you're not able to do it, and it results into a threat to the baby, and then the person is also liable to be, called to the court. Failure to provide appropriate medical care in the prenatal and period and leading to complication due to nuchal cord. Prenatally, if you know the person, you have to take precautions. Failure to identify nuchal cord on ultrasound, if it is present and if it is not diagnosed, then also it becomes a case of negligence. So to conclude, the remedial measures to be practiced, already mentioned, there has to be counseling. Explicit counseling has to be done regarding the complication, and not suggesting an operative delivery. This one have to be very, very careful about these things, and monitoring and detecting problems in time, maybe by ultrasound during antenatal period, by doing a biophysical profile, or doing an NST. You can find out whether the tight nuchal cord can give you abnormal decelerations on the tracings. And during always put in an electronic fetal monitoring should be done, so that you can find out the abnormal features. And if findings are there may be even acidosis, or can be detected by the sampling, the scalp sampling, and do do a good partogram. That also is going to help you in the law, court of law. And documentation again is very, very important. And medical legal, you are not deviating from care and not detecting the thing in the problem that can occur, can cause a person to be at the court of law. Otherwise, if the things are being done normally, I don't think there's anything, because as the concern and emergencies is their section. So that is what I would like to say, that these are the points which should be taken care of when we are doing the cord presentations. Thank you, Ranjana.
Dr. Patel, my question is there.
Yes,
that, actually, nowadays we see there is a changing trend in obstetrics. When we were practicing as postgraduates, the girls who used to come for deliveries were very young. And there was a different scenario altogether. Nowadays, we have basically elderly primaries who are coming to us. And as soon as we counsel them, because ultrasonographists are repeatedly reporting cord round neck. So it is our duty to tell them. So when we counsel them and they ask, is there any risk? So we have to say there could be, but we can take, we will monitor, but we cannot say that 100% there is no risk. Then they will say, then what is the safer option? Why don't you operate and take out the baby? So we have less options nowadays because people themselves are opting, and you can't force them that no, we are going to take you for normal, and only if there's any problem, then we'll shift you to cesarean. Because in that case, if something does happen, then we have a noose around the neck.
Yes. So in all this situation, proper counseling is very much important.
Very important.
And in court of law, whatever you do, you should be in a position to justify your action.
Exactly.
Whichever action you have taken, whether to go for cesarean section or whether to go for normal delivery, but whatever you have chosen, you should be in a position to justify in any given situation. Then you are out of problem, proper record. So you had explained everything to the patient. What was even many a time conversation between patient and ourselves should also be mentioned in other paper, not in case paper, because many times it is also very much helpful in court of law.
Correct.
Yes.
Ranjana, can I add here
I think Dr. Harish wants to say
Ranjana,
yes,
you know, we as a student has been said, elderly primary gravida is an indication for cesarean section. So I think the answer to your question lies over there.
What Madam Ranjana has raised the question, it is a practical scenario nowadays that the people come with sonography report and ask for that. But what Dr. Patel also answered is clear that you have to counsel, they don't know the risk associated with cesarean section. So I just tell them the God has made the natural delivery. Cesarean section is say 7 times more complications as compared to vaginal delivery. Then you wrote down, as Dr. Patel told, that then also if they are agreeing for cesarean section, you can take. Otherwise, that counseling part is very important, that you have to show them the risks. They don't understand. Their friends or relatives or sister-in-law, they are all undergone cesarean section. So it has become a panacea for every small obstetric problems.
Yes.
Can I add something? Thank you, first of all, Dr. Patel,
yes,
Dr. Doshi, and everybody. The talks were so nice that even though after finishing my talk, I thought it is very important to be there all the time, because we are learning all the time. Dr. Manju's comments are so good, because nuchal cord means that, of course, kya kare ki na kare. Should the sonologist report it? Nahi karta to fasta hai, because obstetrician will put the blame. So the blame game thing has to be sorted out, and that can only be done by transparency. Even if the sonologist mentions it, it makes it our responsibility to assess this baby. Is there any growth retardation? Is there any distress? We have to use all the modalities of antenatal surveillance to the best of our ability. And that is only we have good understanding about the NSTs and the color Dopplers, which patient we should ask for color Doppler, which baby will go through the stress of labor. And of course, we all have, I myself have delivered a 41-weeker induced patient, 7 loops around the cord vaginally. So we all have done it, but we all have to be cautious. And the name of the game is eternal vigilance. Vigilance in labor, you cannot compromise, because patients and relatives will not spare you. So we have to be very confident and careful in our assessment of a baby who's going to go through labor. So before going into labor, during labor, and throughout, we cannot let our guards down. Whether it is a nuchal cord or it isn't, we just have to avoid a distressed baby. Thank you so much, and Dr. Patel.
Yes.
Always, it was very nice.
Yeah, it was very nice, Dr. Patel. And
मुझे आंसर पता था, ना लूप है.
Whenever I have any problem, I just ring up Dr. Patel, and he's always there. Immediately, he'll give me the answers.
Yes, madam. I am always there to assist any of our FOGSI friends.
डॉक्टर रंजना, आज आपका टॉपिक तो धांसू था. I was observing कि we had 200+ people.
Yeah.
Good for us.
But let me share one of my experience long back. It was an emergency patient and fetal heart was not audible. We confirmed diagnosis of intrauterine fetal death with ultrasound, and ultimately patient was delivered in due course. And surprisingly, it was found not cord around neck, but cord around thigh.
Leg.
There were leg. There were 3 months, and due to that, that baby succumbed. So it is also possible that it is not necessary that cord should be around neck, and then only it can create problem to fetus.
True.
Yes.
Dr. Haresh, Dr. Mitra, Dr. Patel, I really enjoyed all the talks, and thank you all so much for coming. And I think Neeru, now you can give official vote of thanks. If there are no more questions, are there any questions in the chat box?
One question for Dr. Haresh, that if there is a difference between words cord round the neck and cord around neck.
No, there is no, that is a word, game of words, there's nothing around the neck or around the neck. Scientifically, there is no difference.
No difference.
No difference.
So, Neeru, are you there?
Good evening, ma'am. Good evening, ma'am. Good evening, everyone. I am Dr. Neeru Sahu, going to deliver vote of thanks on the behalf of ISOPARB Prayagraj. It's my immense pleasure to deliver vote of thanks in front of such a renowned personality who made this evening precious. Thank you, Dr. Ranjana, ma'am, to give me this opportunity. Thank you so much, ma'am. First of all, I would like to give my big thanks to ICOG for providing 3 credits points to this CME. Then I would like to express my special thanks of gratitude to our chief guest, Dr. Jayadeep Malhotra, who take out her valuable time for her busy schedule to grace the occasion. Thank you so much, ma'am. Now I move to our expert, Dr. Alka Sethi, Dr. Seema Pandey, Dr. Vasa Mukherjee, Dr. Manju Verma, ma'am, and Dr. Kushag Agrawal. Thank you so much, all the expertise, for your valuable comments. Thank you, our chairperson, Dr. Amita Agrahari, Dr. Surekha Yadav, Dr. Neeraj Yadav, Dr. Gurpreet Batra, and Dr. Archana Messi to chair the sessions. Thank you so much, our speakers, Dr. Ranjana Khanna, ma'am, Dr. Mitra Saxena, Dr. Harish Doshi, Dr. Mayurika Singh, and Dr. MC Patel to deliver their relative talks in such an interesting way that not only the topics is covered very well, but it also groom our knowledge. थैंक यू सो मच. मुझे तो एमसी पटेल सर का जो वो था ऐश्वर्या राय को दिखाया और दिखती है तो बीच में कट हो जाएगा.
She would really die if she saw that. How she would be converted into a gorilla.
So Neeru, keep my visiting card below your pillow.
I wish nobody needs your card.
Yes, exactly, madam.
सर आपके विजिटिंग कार्ड का नहीं, आपका टेलीफोन नंबर हमारे
मोबाइल में into any kind of litigation, but if at all it happens, we are always there to assist.
Yes, sir. Thank you, sir. Thank you so much, sir. And मुझे सर वो आपने रिकॉर्ड कीपिंग पे जो emphasize किया है कि we should keep the record. It's very important thing. आपने इस बहुत अच्छी चीज बताई. हम लोग वाकई में बहुत पुअर होते हैं रिकॉर्ड कीपिंग में, लेकिन अब हम लोग बहुत ध्यान रखेंगे इस बात का. और डॉक्टर मित्रा मैम ने जो ड्रिल दिखाई थी, इट्स आल्सो वेरी नाइस. कॉर्ड प्रोलैप्स में जो ड्रिल थी, वेरी इंपॉर्टेंट ड्रिल. थैंक यू मित्रा मैम. Now, thank you so much, our dear conveners, Dr. Amita Tripathi and Dr. Parul Khanna, to handle the whole session very beautifully. Now, my very special thank you, our beloved and respected and Prayagraj ki shan, Dr. Ranjana Khanna ma'am, who organized this excellent CME on such an important topic जो कभी पहले हुआ ही नहीं. Umbilical cord is such an important topic and सबसे माँ बच्चे का सबसे पहला और आपसी मजबूत बंधन है, और जिसको umbilical cord बहुत खूबसूरती से निभाता है, संवारता है. पूरे 9 मंथ की जर्नी umbilical cord पे बेस्ड है. थैंक यू रंजना मैम. थैंक यू सो मच मैम. रंजना मैम ने अपने अथक प्रयासों से जो प्रयागराज का परचम पूरे देश पे लहराया है, उससे हम सब प्रयागवासी बहुत ही अभिभूत हैं. थैंक यू सो मच रंजना मैम. आपने प्रयागराज को एकदम छा दिया है सब जगह. थैंक यू सो मच मैम. आपका एक बार तहे दिल से शुक्रिया है मैम। अब मैं धन्यवाद देना चाहूंगी अपने ऑडियंस को कि जिनके बिना तो कोई CME मीटिंग हो ही नहीं सकती। जितना इम्पोर्टेंस हमारे वक्ता का होता है उतना श्रोतागण का भी होता है। थैंक यू सो मच अवर ब्यूटीफुल ऑडियंस। और हमारी ऑडियंस बहुत ज्यादा है, इतनी सफल हमारी ये CME हुई है, 200 को क्रॉस कर गए हमारे ऑडियंस जो है पार्टिसिपेंट्स। और अंत में मैं अपने साइंटिफिक संगम के जो स्पॉन्सर्स हैं, एकेडमिक पार्टनर हैं, जैक्सनपाल कंपनी को मैं धन्यवाद देती हूँ, जिनके सहयोग से मीटिंग बहुत ही सफलतापूर्वक संपन्न हुई।
There are some Facebook viewers also, na Deepika? How many total viewers were there?
Over 300 actually.
Yeah.
Wow, that's great. It's a wonderful and excellent, successful CME.
People were there even from Siliguri.
From Kathmandu also.
Kathmandu से एक दो लोग हमेशा जुड़ते हैं मैम।
So before we conclude, let me share one information.
Yes, sir.
Last year, under able leadership of Dr. Alpesh Gandhi as a President FOGSI, we have prepared uniform consent, and now it is available on FOGSI's website. Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared almost consent for 30 different procedures and operations, and it is available on FOGSI website. You can download and use in your day-to-day practice. And if any suggestions as far as these consents are concerned, we are open and always welcome. Because at the time of deciding and putting on this FOGSI website, we had a discussion with Maharashtra Law Society, 2 retired High Court judges, 1 sitting High Court judge, and 1 judge in National Commission in Consumer Fora. And then after we came to this, came out with this consent, because for one word or one line, we had a discussion for hours together many times. And then after we have come up with this consent. So please visit FOGSI website and it will be helpful to you in your day-to-day practice.
So from Jagsonpal, we take this opportunity to thank everybody. My teammates, Mr. Amit Saxena, Mr. Ankit Dogra, and the sales team manager, the regional manager, Mohammad Naim Siddiqui, based at Varanasi, all of them join me, Deepika, to really request your support for our new brand in the making, DIVATRONE. Also reminding you of our other brand, Maintane, which is available as Depo-Progesterone, 17-alpha hydroxyprogesterone caproate, injection 250 and 500 mg, and also allylistanol 5 mg tablets as Maintane tablets. Also, we have LycoRed Preg sachet to prevent pregnancy complications of preeclampsia, IUGR, and oligohydramnios. And we thank you all so much for your presence today. Thanks to the organizing committee, the president and the secretary, ISOPARB Prayagraj, and Rewari, Azamgarh, and Jhansi, all the FOGSI societies together, and ICOG for granting these 3 points. We invite you again for a program tomorrow, which is a Q&A session on Omicron, a new emerging threat, which is organized by DMA. So do register on this Zoom ID displayed, and we hope to see you again tomorrow. Thank you so very much.
Okay.
Thank you so much.
Thank you, Deepika.
Bye.
Bye.
Bye.